Hello, thank you very much for watching this video. I'll be discussing palliative care throughout this, so I'm not going to pretend to be an expert on palliative care. What I'm going to be doing is communicating some learnings that I gained from attending a really excellent education session from the Northern Adelaide Palliative Care Service. I won't be doing it justice, but I'll do the best job that I can. And I'm also pulling some other information from various other resources, such as the RACGP's Silver Book on palliative care, and SA Health guidelines. I'm not going to focus very much on the medicine side of things or symptom management in palliative care. What I'm mostly going to be doing is communicating around palliative care generally, some definitions, approaches, the importance of early planning and anticipating needs, and also how to have quite challenging conversations with people, particularly individuals and their families, but also health professionals. And I think there's some crossover in other areas of practice. Obviously, we'll be discussing palliative care, so end of life, death, and dying. I think it's really important for health professionals to be comfortable with those concepts. Having said that, make sure throughout this video, if anything's making you uncomfortable, do care for yourself, obviously. But I think it is really important for us as health professionals to be comfortable with the idea of death and dying, because it is inevitable, and it doesn't need to be a bad thing. It's a really positive thing when we can provide someone with a good death, and provide someone with the support throughout that process. So I'd like people to come through this and start to see the positive side, and the good side of what we can do as health professionals in this area, and the good side of a good death. So first, some definitions. So palliative care essentially provides care and comfort for anyone with a life-limiting illness. So it's defined as an approach that improves the quality of life of patients and their families, facing the problems associated with a life-limiting illness through preventing and the relief of suffering by means of early identification, good assessment and treatment of pain and other problems. And that includes the physical, psychosocial, and the spiritual aspects of someone's care. Importantly, it's not synonymous with end-of-life care. So a palliative approach recognizes the inevitability of death and focuses on comfort and function in line with an individual's goals of care, whereas end-of-life care is the last few weeks of life. And at this point, this is where the needs of individuals and caregivers are higher. There's commonly a disparity between people where people want to die and where they do die. And I think it's important that we are aware of that, because that's where really good planning, anticipation of needs comes in, and that's where we can reduce this disparity, and provide the opportunity for people to die where they want to die. Anticipating needs. There's a very complex graph on the top right-hand side here that I'll go through. It took me a while to understand it, so take your time. It's pulled from the RACGP's Silver Book on palliative care. On the y-axis, we've got functioning, so from high functioning down to low functioning, and on the bottom, we've got time. So as we progress in time, we've then got certain trajectories, and that we can see their association with level of functioning as time progresses. That shaded area there is where palliative care comes in. And importantly, it is a palliative approach or palliative care. So it's not managing their end-of-life symptoms necessarily, but it's where we start to consider prioritizing their comfort over prolonging their life. So there's three different trajectories in different colors. So the first trajectory is things like malignancies, so cancers, where you'll see there's a fairly consistent functioning, and then there's a sudden deterioration in their functioning. Trajectory 2 is things like non-malignant organ failure, so things like COPD or heart failure. So you can see that there's a fairly gradual deterioration, but there's also little dips. And that's where we might have a COPD or a heart failure exacerbation requiring hospitalization, where there'll be an acute deterioration. They will come back, but they'll come back potentially at a lower functioning than they did previously, up to a certain point where at that stage, if they have heart failure, instead of prioritizing all four pillars and maximizing doses, that's where we might start to consider, optimizing their euvolemic status, ensuring everything's in place for their comfort, and making sure all those symptomatic needs are taken care of over prioritizing their life expectancy. Trajectory three represents things like frailty and dementia, where there's not so much there's a very gradual decline, progressively over time, up until a certain point where, at that point, that's where we start to have that palliative approach where we are setting things up and prioritizing, again, their comfort and their symptomatic needs. So about 60% of people, Australians rather, die between the ages of 75 to 95, and chronic diseases cause the vast majority of deaths. So these sorts of trajectories are really important to be aware of so that we can help to prepare for these declines so that we are able to meet their needs. And this is sort of why it's important to be aware of this. So what we can do if we are able to anticipate these needs is we can improve people's quality of life. We can improve the patient awareness of what's happening and what potentially is going to occur and what the trajectory looks like. We can improve advanced care planning, and we can, importantly, reduce the symptom burden and hospitalisation where appropriate. Now, there are some principles of a good death, and I mentioned a good death earlier. So these 4 principles that I've got down here: knowing when death is coming and what to expect. This provides us with a reasonable control of what happens. It allows us to ensure that people's wishes are respected. It provides us the opportunity to give people the opportunity to decide when to leave and when it is time, and we can avoid prolonging dying. Choice and control over where death occurs, so people can decide who is present and who shares the end. It provides people the opportunity to, with time, to say goodbye, and also time to arrange important affairs. It provides people access to needs, so provides people quality care in any location. Provides people necessary information and expertise, control of pain and other symptoms, dignity and privacy, and also spiritual or emotional support. And then strengthening relationships and relieving burdens on family or informal caregivers. Importantly, at the end of life, it's not just the person who's experiencing that end of life, but it's the people around them. And it provides a good death is one where the informal caregivers and family and friends and loved ones are supported as best as possible. So I've mentioned these 3 trajectories because they're common. They're the more common trajectories, and understanding these helps us to prepare ourselves as health professionals and also the people that we care for. Importantly, they involve I mentioned the functional decline, and that covers the physical, social, psychological, and spiritual, and they're all factors to take into consideration during these times to provide support for all of these needs, not just their medical needs. When anticipating declines and focusing on following someone's trajectory, very general factors are probably more accurate and useful for prognostication than disease-centered variables. So things like people's functional impairment, emotional issues, things like delirium and falls. So you might notice that people start to fall more often during declines in these trajectories, their vulnerability or their resource utilization. So a little bit more on anticipating needs. So prognostication is obviously very, very challenging, and it's obviously not a role necessarily for the pharmacist, but being aware of these trajectories and the likelihood of decline and the common pathways of decline is really important for all health professionals. And it's based on the history and the trajectory. So when we're talking about sort of how long someone has to live, people often will refer to a period of days or period of weeks or period of months, and it's often based on the history. So if someone's been very, very gradually declining, they've been very, very slowly losing weight over a period of months, there's not been any rapid increase in the number of falls or anything like that, we might have a consider that there's a month's prognosis until they reach the end of life. If they have been gradually losing weight, they're increasingly not able to function or participate in social activities over a period of a number of weeks. That's when we might consider that they've got weeks left. And then if someone's having a rapid deterioration, so if they've gone from having no falls to multiple falls per week, if they are they were able to eat solids and now they've been downgraded to only if they're now only consuming a pureed diet, and their intake is very, very minimal, and that's happened over a period of days, then we might consider that they've got days left. Prognostication is also assisted by looking at their age. So older people, people who have recurrent hospitalizations, as I said, sort of impaired nutrition, so their intake has dropped significantly, and the existence of fever, they also all indicate shortened survival. The question that's often used to sort of estimate someone's life expectancy and to anticipate this palliative approach is, would you be surprised if this person passed away in the next 12 months? There's a number of ways to do this. So a lot of medical providers will just use their clinical intuition or clinical trends, but there's also formal tools that can be used for this. So there's this SPICT tool, so the Supportive and Palliative Care Indicators tool, and that's, I've got a screenshot from the SPICT tool there, and it's a free resource that you can just Google and access, and it's a really useful tool to help to identify indicators of deteriorating health. If the answer is no, so you wouldn't be surprised if that person passed away in the next 12 months, that's where we can start to get things in place. So creating a clinical care plan for that palliative approach in terms of that 12-month period, so the getting everything set up. And also, it's an opportunity to get things in place for each step of this process. So the general approach of sort of where they want to be and how they want to spend their last 12 months. And then also the opportunity to identify what happens at the end of life care, the terminal phase, and also after the terminal phase. So importantly, there's a death and bereavement process that the individual will go through, and then also the caregivers and the family will go through. It's important to involve people at this point. So people, residents whose surrogate decision makers have a better understanding of someone's prognosis and the palliative approach, those residents will be less subjected to burdensome interventions, which obviously will affect their quality of life. So it is really important to involve everyone necessary, particularly those surrogate decision makers or the next of kin, in these conversations early and thoroughly and rigorously. So at this point, what we are doing is, if we've identified that this person has we wouldn't be surprised that they're going to pass away in the next 12 months. At this point, we will review their medical care, obviously including their medications, key role for pharmacists, consider a palliative care referral, and I have said consider a palliative care referral as much as possible. Palliative care physicians and teams, nurses, they're really, really key to not just provide the medical care, but also provide that holistic care for people, make sure everything's in place. So I'd say consider the palliative care referral, but do it if you can. Really strongly encourage that. We agree on the current and the future care plan. Plan ahead, particularly if there's any potential for a decision-making capacity to deteriorate. So people with likely cognitive impairment and decline, and make sure you're recording, communicating, and coordinating that care plan, particularly with all staff members, particularly if within that team, but also to the next of kin or the surrogate decision maker. So when we're planning throughout this process, when we're anticipating someone's needs, this is the Pepsi Cola acronym is specifically designed for GPs, but I think it's really important and really helpful for for all health professionals to be aware of. So it covers all the domains and all the areas that we should be considering and putting plans into place to support this person at the end of life. So not just focusing on their medical needs, but focusing on the holistic needs of each individual. So there's the physical symptoms. So addressing symptoms like pain and breathlessness and fatigue, and putting a plan in place for how to manage those as they deteriorate or as they develop higher levels of needs, and also other manifestations of their illness. So whatever other medical conditions they have, making sure if these are going to deteriorate, we've got plans in place to manage these symptoms. And then considering issues related to mobility and sleep and nutrition and all other physical care needs. And then obviously deprescribing comes into that as well. Emotional needs, so recognizing and managing complex emotions. So often fear and anxiety, or anger can come around here. So it's important to be aware that these may happen and they may change over time, and being preparing to acknowledge and manage these emotions. And obviously managing these through psychological supports and interventions. And importantly, I think it's also good to note here that it's not just the individual, but it's also their family and their caregivers and staff at the aged care home. If that's where you're practicing, everyone's got these emotional needs. The personal, so the spiritual needs. So I'll comment on this a little bit later, but spiritual needs are not just religious. So they're the needs of someone that is beyond the physical, essentially. So addressing their religious needs or their spiritual needs, and also the person or the carer's support needs. Social supports. So considering the social environment, like relationships, other social needs, living conditions, addressing challenges to caregiving, financial concerns, or any other social factors. Information and communication. So making sure that they are the person and their family have adequate information about the disease and the prognosis, treatment, expectations, providing resources and educational materials, but also the team. So the multidisciplinary team, if you're practicing within an aged care home, making sure that everyone is on the same page and everyone is able to recognize things like deterioration or their prognosis to avoid any uncomfortable challenges where someone isn't aware of what's going on, saying the wrong thing. That's really important. So it's not just the individual, but it's all the healthcare professionals around them. Control, so respecting and addressing any cultural beliefs and customs and values of the person and the family, being aware of cultural practices or rituals that might be related to end-of-life care that you may not be aware of. So different cultures and religions will have different needs and expectations and traditions. And particularly things around where they want to die and what will happen to them after they've passed. And yeah, just ensuring that the person's rights are upheld. So O is often out of hours or organisational. So addressing any carer support, continuity, making sure that things are in place for urgent needs. So there's such a thing as a palliative care emergency, and that's important to be aware of what might happen in this particular illness. Making sure you've got access to the right things and the right people. Um, and the O often also stands for organizational, so addressing things like advanced care planning, wills, powers of attorney, ensuring care coordination, things like that within the system. L for late. So this is for the terminal phase. So making sure you've got access to the right end of life drugs. You've organised anticipatory prescribing, injectables and syringe drivers, comfort measures, and then spiritual care throughout those last days, and then afterwards. So we talk about death and dying. Put it around the wrong way. So it's dying, and then there's death, and then after that, there are still things that we need to be aware of. So bereavement and support, any assessments that we need to do to quality assurance mechanisms, and this is particularly where family support comes in. So this has been really useful for myself personally. I've started to, when I'm discussing these sorts of things with people, I'm actively asking people whether they themselves have access to support mechanisms throughout this process and then afterwards as well. I think that's a role for any healthcare professional that is not stepping outside of scope. Spiritual needs, I commented on this before, but spiritual needs are not just religious needs. So spiritual needs are the meaning and the purpose for someone's life beyond the physical world. And it's important to acknowledge that these needs can be quite complex, and that they can't just be managed by anyone. So I think it's really important to acknowledge that we do need, there are experts in this area, just like when we talk about palliative care, we have palliative care experts. When we talk about heart failure management, we have cardiology experts. And in this area, we do have experts. And where it's really important that we refer where appropriate to these people. It can't just be managed by anyone with a nice smile and a can-do attitude. So psychologists and counsellors are obviously key. Social workers, pastoral care workers, they're all really, really important. I think it's important. Pastoral care workers are not just, they don't just have a religious leaning towards their input, but it's pastoral care. So they do have a role to play, and a really important role, and a really influential role in these areas. And it's not just religious. So that can be a misunderstanding that they are only coming at it from a religious perspective, and that certainly can be the case. But they do have a holistic management approach to these things. And if we don't do it well, it can cause problems. So if we're opening up these conversations with people and we're not prepared, we can do harm, basically. Just like if we're not prepared to have a complex deprescribing conversation with someone, we can do harm. So it can complicate emotions rather than helping things. So we can cause things like guilt and anger and confusion. And if we can't manage these, so if we're not the expert in this area to help manage these emotions, that can be harmful. And when we're thinking about their spiritual needs, think about the connection with people and with locations. So some people, me personally, I am not a religious person, but I have certain things that I prioritize in my life, certain people and certain things around me that have meaning for me. Talking to people about that can help to identify what might help them. So things might not be clear. They may not have a clear religion or a clear culture that they can rely on. But there are things that are spiritually important to people, and digging into these a little bit, identifying sort of who's important, what's important, and where is important to you can help provide some guidance on who to reach out to and who to sort of involve for those spiritual needs. So, for example, uh, there was a story relayed to me that someone in their last days of life, what they really wanted, where they wanted to spend that time was um, uh, in underneath an acorn tree with sunlight filtered through the leaves, with the smell of all of that. That wasn't possible. But what they could do was set up things like involving people in their walking group to bring to the room, putting in certain mechanisms for light into the room in which they were. So they had the right people in there, the right sort of atmosphere. They had incense burning, and I think they had some music playing in the background, some sounds of birds. So there's ways to meet people's needs, their spiritual needs, without necessarily, even if there are barriers in place. Importantly, I do want to emphasize get the right people involved for that. So, pastoral carers, particularly if you're in an aged care home with access to this, pastoral carers are excellent. Otherwise, volunteers from certain cultures or organisations can be really helpful. Talking to the leisure team is really, really valuable for this. Some insights that I've learnt from other people: try and be creative for memorials when appropriate. So some organisations get gardens together with little rock gardens. There's memorial books, or there's regular services, so monthly services where people honour those who've passed. Making sure there's information available for informal caregivers. So having information within the aged care home, if that's where you're practicing, or wherever you're practicing really, good information, physical and digital information to provide to caregivers, to provide them with sort of information. Things like art and music therapy, massage and aromatherapy at the end of life can be really, really useful. Um, Challenging conversation. So these sorts of uh, conversations with people around death and dying and palliation are obviously can be very, very challenging. They're important to have and they're necessary to have and they are going to happen, but they are challenging. It's really important to have good communication. We always talk about good communication skills. Sometimes it's just making sure you're talking to someone's health literacy, but I think good communication skills comes down to really, really solid foundations in empathy and the really good emotional intelligence. And it is really, really challenging. And it comes through learning, but also practice. And it's important. So, good communication not only benefits the individual that we're caring for, but the entire team. It improves adherence to therapy, and it also can overcome medical legal issues, or it can avoid them. Clear and accurate information that's well communicated can improve understanding the rapport with individuals and their families, and it also provides us with the ability to provide for individuals to provide informed consent. And I think that's really important to come back to sometimes. We talk about informed consent or consent. Truly informed consent requires that someone fully understands what they are consenting to. So it requires them to not only be given certain information, but to understand the information and understand that information fully. And that's a lot more complex, as I'm sure we can all appreciate, than just, if someone's wanting to consent to starting a medication. It's more than just providing someone with the risks and benefits in terms of statistics, but making sure that's actually meaningful to the person. I think that's where things like empathy really comes into play. So empathy versus sympathy, there's a different concepts. And I think we need to prioritize empathy over sympathy. So empathy is where we bring people together and make people feel included. So it's more of I think of it as more of an internalized sort of thing. Whereas sympathy is more externalized, where we create an uneven power dynamic, and it's more of maintaining that hierarchy or paternalism of healthcare, and can lead to isolation rather than someone feeling included in the conversation, and then being fully not being fully informed and fully part of that conversation. So just generally, when you're starting conversations, any conversation with someone around any topic, introductions, make sure they know who you are, what your role is, and make sure you know who that person is and everyone else in the room. So making sure you're not making the mistake of coming into a room, talking to a person, and then realizing there's a key family member sitting in the corner that you need to include in the conversation. Plan. So identify why you're there, what the conversation is going to look like, and then get consent to discuss it. So say, you're here to talk about, the ongoing need for these certain medications. You just want to have a chat about what their goals are, what their understanding is of the situation, and what they prioritize at this time. Do you mind if we talk about that? Is this a good time? Would you like me to come back tomorrow? Would you like me to come back in a little bit? Are you in the middle of your lunch? That sort of thing. In terms of what people want from conversations, obviously everyone is different, but generally speaking, what people want is the truth. They want honesty, and they often also want additional information. So people don't want to come out of a conversation with more uncertainty, and they don't want to be provided information in a way that's not really authentically or truthfully conveying the situation. This is going to come in a little bit more of a delivering bad news or giving people new information around their medical condition, which very likely is not a role for the pharmacist. But I think it's important to be aware of sort of what people sort of expect and how these conversations sort of go. And I think it has a lot of crossover and guidance for pharmacists. A couple of key points. So there's literature that suggests that just sitting can give the perception of a longer conversation. That's not to say that you should just have a very quick conversation, but as long as you sit down, it's okay. But sitting with people can give you the perception that it's been a more rigorous conversation. And it's really important to be aware of, and I'm sure everyone probably is aware of this, but as emotion rises, so as you have more heightened emotions, your ability to think clearly decreases. So your capacity for cognitive tasks decreases. So this is important to be mindful of because it can doing things like creating space and allowing silence, which can be very, very uncomfortable, but allowing that sort of space for people to think through their emotions can be really productive for a conversation, and it can provide. If we're constantly talking and discussing and filling silence with conversation, we don't really allow someone to think, reflect, take a moment, and then really identify sort of where they want what they want to ask. Now, this acronym, the SPIKES acronym, as I sort of said, it's more useful it's more used by medical professionals. So it's designed as an acronym to be talking about delivering bad news, so delivering a diagnosis, which is beyond the role of a pharmacist. However, I think it's a really useful framework to approach conversations. It's one that I've used when I'm talking to someone around deprescribing or symptom management, and sort of the best options that I can suggest and speak to the GP about during an end-of-life or palliative approach. So for me, it's useful for those sorts of scenarios. First of all, setting up, so making sure you're in the right location, making sure you're in a private location, make sure you've got the right people there. So, discussing with the person, I want to have this kind of conversation with you about your medications at the moment. Do you want anyone else involved? Would you like to, are you happy sitting here in your room? Would you like to pop out into the garden? Where would you prefer to be? Make sure you're prepared. So make sure you've got all the background knowledge with you. Make sure you've got some resources with you to support the conversation if you need or you think that's going to be necessary. Ideally, being seated. Something that I'm trying to focus on doing a little bit better is when I'm coming into someone's room, I was originally quite hesitant about sitting on their things, sitting on their bed and sitting on their chair. Now I realize, I don't want to be standing over someone having that conversation. I want to be on the level with them, regardless of the type of conversation. I want to make this a situation where we're both on the same level, and particularly in these kinds of conversations where you're discussing these sort of quite emotional topics. You want to be sitting at the same level as them as much as possible. And then make sure you've got time. Make sure you're not going to get a phone call at this time. Make sure your phone's on silent. Make sure you haven't got a meeting that you suddenly need to run out to. Make sure they're not going to be interrupted by lunch with someone coming in with their lunch. And then perception. So gaining their perception of the situation. So asking them what they understand about the situation. Say, like, I want to talk about your medicines. What's your understanding of your medical condition at the moment? What's your understanding of sort of what the plan is for yourself at the moment? And then listen to their level of comprehension of what they have to say. And then, importantly, if they are sort of perhaps not sort of aware of the situation or they're not conveying the same understanding that you had, accepting that and not confronting it at this stage, and then sort of revisiting it as appropriate or getting someone else involved to revisit that, maybe getting sort of the GP in with you to sort of have that more rigorous conversation to make sure they do understand what's going on before you have that conversation. And then invitation. So not going in and providing information immediately, but asking for an invitation from the person to give information. So ask if they want to know a little bit about what you have to say about the medications. You may be coming in to make sure that they, we've got the right things in place for their pain, or they're keeping their bowels moving along, or we might be reconsidering the ongoing statin usage. Asking if they are want to have this conversation and want to receive that sort of conversation. Very much accepting their rights if they don't want to have that conversation with you. Then checking if they would like to have the conversation at a later date. Asking if anyone else, if they'd like information from anyone else, and offering to answer those questions at a later date. And then knowledge, so delivering that information, giving the facts, use obviously appropriate language for the person's health literacy and also their state of mind at that time, considering their education level, sociocultural background, and, as I said, emotional state. Constantly checking, so making sure that they have understood what you've said, using some feedback tools to sort of check their understanding and giving information in quite small chunks. So not saying, we've got your cardiovascular medications, you've got your ACE inhibitor and your statin, we're going to, we're thinking of stopping those, are you okay with that? Going through one by one, checking their understanding of what you're saying, and then providing an opportunity for them to ask and clarify anything that they need to. Importantly, again, using that emotional intelligence and that empathy to gauge how they're responding, both verbally and non-verbally. And always framing things around meeting their goals rather than withdrawing treatment. So avoid saying, and this is more with delivering the diagnosis, and avoid saying there is nothing more that we can do. As a pharmacist, that's perhaps not the conversation that we're going to be having, but instead focusing on, I can see that you've been using the oxycodone a little bit more frequently in the last few days. It seems like you might be in pain. What can we do to is that working for you? Are you using it regularly enough that we need something in place that's a little bit more stable for you? Um, what do you prioritize at this time, and then how can I help to meet that alongside the rest of the team? Empathy or explore or emotions. So importantly, not sympathy. So we're not having that paternalistic, hierarchical conversation. We're meeting the person where they're at, observe their emotion, identify and inquire about the emotion. And this will come into the next slide, an acronym. Ask about the reason behind the emotion, and then let them know that you've genuinely understood the emotion. If you haven't understood the emotion, clarify it and qualify it. Things like, I can see that you're surprised because this is not what you wanted to hear. And this is a really good time to allow people the time to sit and think. So don't be afraid of uh, awkward silences. So I think they're things that I struggle with, but it's really important to allow people to be to sit with their emotions, work through those emotions or work through those thoughts, and then be able to have a rational approach to discussing it, and then not being afraid to, at this point, if they need time to consider if this is becoming overwhelming, taking a step back and saying, would you like me to come back? Lunchtime's coming up. Have a bit of lunch and I can pop back later on. Would you like to discuss this on another day? Depending on sort of their needs at that time, that might be appropriate. And then summarizing or strategizing. So, close the conversation, summarize the discussion and the plan. This is a really good opportunity to, again, check their understanding, see if they've developed any other questions, ask whether they want to clarify anything, set an agenda. Importantly, throughout the palliative approach, particularly when we're sort of deprescribing in these early stages, we don't want to do everything at once. And really important part of informed consent is that consent needs to be ongoing, otherwise it is not consent. So there is always going to be the opportunity to make a decision at this point, and then revisit that in a few weeks or a few months. It's always going to be an ongoing collaborative discussion about needs, and those needs might change, and that's fine, and that's really important to be aware of. Further challenging conversations. Sometimes, and I'm sure everyone's probably experienced someone who's been very angry, when there's actual conflict or potential conflict. This acronym, the NURSE acronym, is useful to use to be able to manage that conflict. And I think it's well named because I think nurses are often quite good at managing conflict. And this can occur. Emotions are heightened. This has crossover to a lot of other sort of areas of practice, but particularly in this sort of area, people will have heightened emotions and may react quite emotionally, and that can lead to conflict. So this acronym is useful to address that. So N is for naming. So naming the emotion. So identifying what someone is feeling. If someone's coming in, you've got a family member who's stormed into your office and is demanding to speak with you. It's important to identify it. Sort of, I can see that you're worried. It sounds like you're worried about what's happening. Try and avoid naming it in a negative way. So avoid putting a negative definition on something, such as, I can see you're angry, or I can see you're confused. That can, if you're incorrect, that can worsen the conversation. But name it, and particularly name it in an exploratory way. So it sounds like you're worried. Is that what's happening? Or I wonder if it seems like you're upset by what's happening. Is that the case? Um, then going into you for understanding, so show that you've understood the emotion. And what they um, the emotion and what they are actually saying. So clarifying like with that emotion. So am I right that you're worried because you're concerned that your mother will experience pain, and they may be concerned that things aren't in place for that. R for respecting. So acknowledging that they are, depending on what precisely is happening, but recognizing that they are advocating for their family member, saying, thank you for raising this concern with me. Thank you for talking to me. Your mother's lucky that she's got you supporting her. Thanks for coming to me with this. Saying that it's okay to be worried. It's okay to be uh, upset about what's going on. Sort of what you're and sort of acknowledging and meeting them where they're at with that empathy. So saying that what you're going through would be hard for anyone. I can understand that. Supporting them. So showing concern and expressing a willingness to help, saying sort of, what we can do is, if you're concerned about the pain management at the moment, what we can do is we can discuss the options with the GP about how to manage this. We want her to be comfortable, and if starting something would be helpful, that's what we want as well. Something that I found really useful is telling them that I'm here certain days, certain times to support medicines management. Any questions, any issues that come around, tell anyone to come and get me, and I'll talk to you or your family member through these through whatever issues. And I'll support you as best I can, and I will liaise with the rest of the team, particularly the GP, to make sure everything's in place to support your mum's needs or whoever's needs at this time. And then E for exploring. So asking sort of exploratory or follow-up questions. Exploring, asking them, you came in quite worried. Is there anything else that's bothering you? What can I do to help? What are your concerns? Starting off a sentence with "I'm curious" can be really helpful. So I'm curious. Tell me more about that. If they've sort of expressed something that's sort of allowing them to not vent, but allow them to sort of elaborate on what's going on with them. So yeah, I'd encourage you to read through these in your own time and play on scenarios in your mind around how you might be able to put this into practice. It's very challenging to have an acronym and then put it into practice without sort of rehearsals a little bit beforehand. Going past sort of those how to approach certain conversations into more specific. So people might experience requests to hasten death. So particularly with the availability of voluntary assisted dying nationally at the moment. I've certainly been involved in conversations where someone has either very strongly alluded or asked about hastening death. And that's can be a very challenging conversation to have. There's something called the doctrine of double effect, which is essentially it's a moral concept where an action is permissible if the primary intention is to do good, and B, the action is either good or neutral. So what the action that you're taking can't be objectively harmful. The good effect is not produced only by the bad effect, and if there's proportionate rationale for the bad effect to be a potential outcome. Now that's all related to the moral philosophy side of things, but essentially in healthcare, what that means is if the primary intention is to alleviate a symptom, and particularly we'll be talking about pain here, an unintended consequence such as death may be permissible. And this is only the case where the action is proportionate to the symptom. So, in things like managing pain, if we are managing pain and intentionally managing pain, and our intention is to relieve the experience of the pain symptom, then escalating doses is appropriate, provided it is relieving those symptoms, and that's the intention behind it. If the intention behind escalating doses of opioids is not to alleviate pain and it's not proportionate to the pain experience, that's not covered by this sort of doctrine of double effect, because the intention behind that is not it becomes clear that the intention behind that is not to alleviate that symptom. So when asked by someone to hasten death, basically it's really important to be aware of the legislation in which you're practicing. You might be able to provide resources or referrals where appropriate, but essentially what you need to do as a health professional and what you should do is to very, very clearly state what that legislation is. So it requires you to understand the legislation intimately. Inquire about what they need that is within your capacity and explore those needs and identify ways to meet their needs that is within your ethical and legal obligations as a healthcare professional. So not dismissing them and certainly not, I don't need to say this, but certainly not doing anything that is transgressing any legal or professional boundaries. Advanced care planning. So I'll just very briefly touch on this. I'd encourage you to talk to any of your nursing colleagues. They are exceptional at this sort of thing. But essentially, advanced care planning is the process of discussing, determining, and documenting someone's preferences for future care. It provides individuals with a voice in healthcare decisions when they might not be able to speak for themselves. And it helps set up expectations for the person and their informal caregivers. An advanced care directive as a legally binding ceiling of care, and it's important to recognise that it's the ceiling of care. It doesn't mandate that anything in that directive must be done. It's still at the healthcare provider's discretion as to whether that will be done or not, but it provides a legally binding ceiling of care. It doesn't mandate that someone needs to provide a particular treatment. Throughout this process of advanced care planning, these are often for individuals, but it's important that when doing this, particularly if you're working in an aged care home, that everyone, including care staff, nursing staff, allied health professionals, are able to recognise symptoms of deterioration. And this is where really useful signage can come into play. There are information sheets and things like that are available. I would encourage you to go through that QR code will take you through the Australian Commission on Safety and Quality in Healthcare resource site, but making sure all staff are able to identify signs of deterioration. Some little conversation tips around advanced care planning, starting it early, as early as possible. Earlier advanced care planning has many benefits to organisations, individuals. Making sure you've offered a support person to have that conversation, communicating openly and honestly, checking people's understanding. So again, giving bite-sized chunks of information and then checking understanding, allowing time for the conversation and then allowing time for people to understand and think about it. And that will come down to informed consent, so that people have had adequate opportunity to really consider their needs and their goals. And then be curious. So ask, and this sort of comes back to one of the points previously where, in ask for an invitation to provide this information. Ask how much they want to know or be involved in decision making, who they would like to be involved, and ask what matters to them. Overall, advanced care planning, it helps the patients, the families, the clinicians, and organisations to clarify plans, goals of care, and importantly, the limitations of medical treatment. Now, this is where I'll go into a little bit on symptom management at end of life. So this is a quick little acronym for the main symptoms to be aware of. So pain, agitation, nausea, emergencies, respiratory symptoms, or other symptoms that are specific to particularly the chronic illness that may be the cause of that may be the life-limiting illness that they are experiencing, or other illnesses where they might experience deterioration and need symptom management. And this will help to sort of inform deprescribing choices as well. Yeah. With identifying symptoms, there's a range of tools that can be used to help identify and help guide symptom management. There's a few things importantly with things like pain and other symptoms, there's a big discrepancy between what different people, different people will measure pain in the same individual. So individuals will typically be able to self-identify pain well themselves. They may not communicate that to others, and that's important to be aware of. But clinicians, healthcare providers will often rate pain symptoms as lower, whereas family members of individuals might rate pain symptoms higher. So it's really important to get information from the person, or sort of be aware that there might be discrepancies between your perceptions, family members' perceptions, and the individual's perceptions of their experiences. Some other just more interesting things is older family members often overrate pain, whereas younger family members tend to underrate pain. So it's very, very variable. It depends on someone's context and their background, but important to be aware of these sorts of things when making decisions. I'd encourage you to have a look at these scales, and these often some of them are patient-reported measures, so they're useful to be aware of. They've got different pros and cons to be able to measure symptoms. A few other key points. So people, certain older people, maybe may have particularly older males, maybe quite stoic in reporting symptoms, particularly around pain. I'm sure many people have sort of identified this. That's important to be aware of, that, we need to rely on what people are telling us, but also be aware that we might need to dig a little bit deeper and ask follow-up questions and use other methods to support people as best as possible, whilst still recognizing that they need to offer informed consent where appropriate. Some people may not report symptoms because they might be fearful that that's a sign of progression of their disease. So that's important to be aware of. And also, some people may have had a negative history with healthcare professionals. So it's important to be aware of people's contexts. So that would dictate how they respond, how they sort of interact with us as healthcare professionals, particularly if they've had a negative experience in the past, which unfortunately is not uncommon. Make sure you're aware of cultural differences in symptom meaning. Make sure you're aware of people's communication, their health literacy, and the way that they communicate, which is where using family members can be really useful. And then also people may be demoralized, and that may play a role into how comfortable and how willing they are to express their needs, because they may feel demoralized, and particularly older people, they may not speak up regarding certain symptoms. So it's all really important to be aware of. There's various classical, as I said, with the acronym, there's many symptoms that we need to be most mindful of throughout a palliative approach, and particularly at end-of-life care. I've taken these screenshots from the SA Health guideline on prescribing in the last days of life. It is a publicly available document, and I would encourage you to access that. It's going to be very, very similar to the therapeutic guidelines palliative care document, up to date. The RSCGP, there's many, many guidelines that you can access. Now, when you're thinking about pain, I think people often think about it with malignant conditions, but it's very, very common in non-cancer end-of-life situations like heart failure and COPD. A couple of key points that I probably don't need to emphasize here, but transdermal opioids for end-of-life care, such as buprenorphine, is generally not appropriate. Breakthrough pain is really common. Make sure there are PRN doses available, particularly if there's a continuous infusions and continuous access to opioids. Make sure that there are PRNs available as well. But obviously, with persistent pain, make sure that there is a constant dosing to support that stable baseline management. And then the standard principles of start low, go slow, particularly with opioid naive patients. These fundamental principles of medication management still apply. If someone's had more than 3 breakthrough opioid doses within 24 hours, consider changing the management and consider escalating the regular dosing. I won't go through the specifics of dosing there, but keep in mind that these are for opioid naive people. And if they are on high dose opioids previously, there's various calculators you can use. There's a Faculty of Pain Medicine opioid calculator that you can get on your phone, and that's done by the Australian New Zealand College of Anaesthetists. Really useful app, free app to have on your phone. If there's regular opioids in the background, particularly prior to transitioning to a subcutaneous administration method, consider a continuous subcutaneous infusion, and again using opioid conversion charts. And for PRN doses, usually 1/12 of the total daily subcutaneous dose every 2 hours is used. Depending on prognosis and timelines, it may or may not be more important to consider aperients, but yeah, do make sure that is considered, because we don't want to be then causing constipation and impaction from trying to alleviate symptoms. Nausea and vomiting is also particularly common. Metoclopramide is fairly commonly used. Haloperidol, I think there's some hesitancy around using it for individuals, but there are benefits to it. So it is often recommended to use it, particularly if there's ongoing agitation or potential delirium, for short-term use for these sort of end-of-life periods. It's also not considered chemical restraint when it is used for symptom management in this scenario. That's important to be aware of. If it's persistent, don't be afraid to use it regularly. So through a continuous subcutaneous infusion. Metoclopramide is considered first line, up to 3 times daily as required. If it's persistent and it's not responding to the metoclopramide, you can add haloperidol, and seeing which one's more effective, essentially. So if the haloperidol is being used and it's more effective, consider that as a subcutaneous infusion. Over 4.5 milligrams per 24 hours is where extrapyramidal side effects of haloperidol are going to be more common. So if you're using relatively low doses, they're less concerning, less likely, but still be aware of sort of akathisia or restlessness, tremor, dystonia, rigidity, or tardive dyskinesia. Um, Respiratory distress is another very common scenario that people experience. Oxygen does have a place in therapy, so there's not really good evidence that supplemental oxygen for um, shortness of breath and dyspnea um, and low oxygen SATs. There's no good evidence that it is actually effective for people in reducing symptoms or in improving sort of patient reported measures. However, it is used and it does have a place. What it shouldn't be used for is to prolong someone's life. Using supplemental oxygen if they're in respiratory distress, particularly if someone's got a history of a respiratory airways disease such as COPD, using supplemental oxygen if you're treating their distress can be appropriate. What you shouldn't be doing is treating just their respiratory rate or treating their oxygen saturation. It's only to relieve distress at the end of life. So if they seem like they are short of breath, they're not getting enough oxygen, and that's causing them distress, or if it's causing the family members distress, it can be appropriate to use it, but it shouldn't be used ongoing without that in mind, because the goal at this point is symptom management, and uh, these objective markers of O2 sats, unless it's causing distress in the person, that's not we're not sort of trying to treat the markers. It is common, and it's common in people even if they don't have things like heart failure and COPD. So up to 24% of people at the end of life can experience dyspnea. Try and use validated questionnaires. So there are general questionnaires or there are COPD specific questionnaires around their level of respiratory distress if they're able to self-report. If they're unable to self-report, there's the respiratory distress observation scale that can be used. Opioids can be used for this dyspnea, particularly in COPD. However, they're used at lower doses, so 1.5 to 2.5 milligrams every 2 hours of morphine, or equivalents of fentanyl and hydromorphone in the setting of renal impairment and other such things. Anxiety. So if someone's distressed and it's suspected that it's an anxious or anxiety-induced distress, benzodiazepines can be used. So subcutaneous midazolam or oral clonazepam can be used, depending on the appropriateness for the individual. If they're on regular benzodiazepines prior to transitioning to a subcutaneous route, convert it to the subcutaneous route using a calculator. However, be mindful that this is always just going to be an estimation. And for respiratory secretions, hyoscine butyl bromide is used 20 milligrams every 2 to 4 hours, up to a maximum of 120 milligrams per 24 hours. Really important to note that that sort of the secretions in the throat, so that sort of gurgling sound, can be really distressing for family members and other healthcare professionals. It's generally not distressing for the actual individual who's experiencing it. So often, again, comes down to why you're using it. Just treating the sound is not necessarily necessary. It should be used to relieve distress, whether that's the individual or including the caregivers. Restlessness and agitation is quite common at the end of life. It's common and multifactorial. Generally, we would say if someone's restless and agitated, investigate the why they're having these behaviours. What are the unmet needs? Investigating the causes very likely isn't appropriate at the end of life. So we can safely sort of manage it as we need to. But make sure you are, if there are clear identifiable causes for them being restless or agitated, make sure you do manage those. So things like pain, of course, urinary retention, fecal or rectal impaction, hypoxia. So managing that those respiratory symptoms, any environmental factors or general distress. So unmet needs. If they can be clearly identified. Non-pharmacological measures are still appropriate. So making sure you're putting things into place, not just commencing the medications, but making sure you're making sure they're in an environment which is as comfortable as possible, as familiar as possible. This, of course, may not be possible, depending on logistics and if you're in a hospital setting, it's challenging, but there are things that you can put into place to make the environment more comfortable for them. Avoiding really dark or bright light, reorienting them, all these non-pharmacological measures. Low-dose benzodiazepines can help manage the symptoms, and also low-dose haloperidol can help to manage particularly delirium or these sort of the agitation. We obviously think about things like starting an antipsychotic for agitation as inappropriate at these moments when it's when we're meeting their goals at this time. It's appropriate. And as I said before, extrapyramidal side effects are more common in doses 4.5 milligrams or higher per 24 hours. I won't go into detail on the doses for benzodiazepines. Probably something that's important to note is the community palliative care list does recommend oral clonazepam. That's because of a pragmatism around PBS availability and affordability and things like that. If you're practicing in an aged care home, I would discuss with the team and the facility what's possible to keep on impressed and what's going to suit the needs, because you will come across these people who need things like this over time. So yeah, have that robust discussion. It's a role of a pharmacist to make sure you've got an impressed stock that meets the needs of people or the potential needs of people in a timely way. Consider a syringe driver, so a continuous subcutaneous infusion. If people are regularly using PRNs or if they're on pre-existing benzodiazepines, we touched on that a little bit earlier. If they're on a regular antipsychotic, consider conversion to, continuous subcutaneous infusion. And for delirium, as I said, antipsychotics can be useful. To summarize, there's some resources down here. Essentially, death and dying is a component, and it's an inevitable component of healthcare. We all need to be confident and comfortable in discussing these sorts of things with the people that we care for, and we all have a role to help someone to achieve a good death. Palliative care is everyone's business. It's a team sport. It's a team approach. It is also a specialty area, so constantly be upskilling yourself, but also involving a palliative care team as much as possible and as early as possible is a really good way forward. And make sure you're prepared for challenging conversations. So get those acronyms in your mind. Use them in sort of mock scenarios if you can. Engage with your peers and your colleagues to sort of trial these out so that you are prepared to have these conversations when they arise. Please access all those resources. There's my references here. And thank you very much. This has been a bit of a long one.